people deserve this. They deserve the ability to shop, to see how their wealth is going to be impacted by their health. It is not, hey, we're just launching a new plan. This is something that is mind-blowingly change.
Hello, and welcome to the Self-Funded with Spencer podcast, a show that cares about healthcare. Each week, we sit down with some of the top industry minds to discuss how this healthcare system works, what solutions actually deliver results for employers, and how do everyday Americans get access to better and cheaper care. So whether this is your first day on the job, or you're a grizzled industry veteran, or if you even randomly stumbled upon this podcast, I promise you that this show is full of information to help you understand this crazy world we call U.S. healthcare. So thanks for tuning in to the Self-Funded with Spencer podcast. Let's go make healthcare better together. But why don't we introduce you, Kylie Everhart, right?
Kylie Everhart.
What is your role at Oxbridge?
I'm the Chief Growth Officer for Oxbridge.
So define a Chief Growth Officer for me, because that is a title that I see coming up a lot more these days. You know, I'm accustomed to Chief Revenue Officer, Chief Sales Officer. Mm-hmm. Differentiate a Chief Growth Officer for me. Is that more of like early stage growth? Is that why that designation exists? Or
it's early stage growth. I mean, essentially, I am the Chief Revenue Officer, Chief Sales Officer. We call it Chief Growth Officer. I came on to Oxbridge prior to even being in the market. We're just now entering the market with quotes for 3-1.
3-1-25.
3-1-25,
yeah, okay, cool.
Yes. And so what I came on to do was to really prepare this product and this market for what we are doing, which is really episode benefit plans.
Yeah, let's define real quick for the audience that's tuning in, right? Like, what are we going to cover today? And then I'd love to hear your backstory, because I think you were uniquely experienced and positioned to take on this role because of what you've done in the past. But real quick, what would we define Oxbridge Health, or these episodes of care? How would you describe that?
You know, in a nutshell, Oxbridge Health is a new health plan that is coming out that breaks out episodes of care, which is really anything procedural, chronic condition, that we bundle all of the components together from diagnosis to recovery.
Okay.
And we bundle that into one payment and make it shoppable for the consumer.
Yeah. Well, and the shoppability, which I really want to get into, and I think the structure with the way the employees and the employers share in that structure, the financial structure of that, and the way that creates choice still for the employee. I want to make sure we get really deep in the weeds on that. But let's take a step back real quick with you, Kylie. Let's talk about you for a moment, if you don't mind.
Absolutely.
Give us a little bit of your bio, if you could.
Sure. This is my now 23rd year in health insurance. I've been on really every single component of it. Agency, carrier, payer, provider, with a really strong emphasis in ACA and Medicare.
Okay.
Which, like you said, I think gives me a very unique viewpoint into the world of employer health. Because I am so focused, you know, the ACA and the Medicare, we really focus on the consumer, the individual. I mean, it is individual healthcare, right? And so bringing that into the employer space and really focusing on the end user, the consumer, that employee who really just needs a little bit more help, more sophistication to understand their healthcare spend.
And how did you find yourself in this business in the first place?
You know, that's interesting. I moved to Dallas. I moved to DFW, which we are right now. I don't live here anymore. I found an incredible company called Health Markets, which a lot of our executive team was with Health Markets at one point in time or another. We actually overlapped a little bit, and just really found this niche. I kind of stumbled into it, but found this passion for healthcare and health insurance. Probably the most boring thing to be passionate about.
I'm passionate about it as well, but your average person is probably thinking we're crazy for thinking that. So how did you find a passion for it?
You know, when you see behind the curtain of healthcare and health insurance and how it impacts everybody's daily life, even if they don't think about it every day, something with health insurance, something with healthcare will impact you every day. Whether it's your medical, your vision, your dental, every single day someone is being affected by that. And I've heard stories. I mean, I started my career as a customer service representative.
Okay.
And so I've listened to those frontline phone calls. I listened to how people are impacted by their insurance at the most vulnerable time of their lives.
It's the right word, vulnerable. Yeah.
They're sick, they're scared, they're worried about their finances. Insurance is about health and wealth. It protects your health, it should protect your wealth. And that's how I think about insurance. And so I've dedicated my life to this.
Well, and not to be too lofty in the way that I kind of respond to that, but I think our model of healthcare right now is kind of failing on both fronts, on the health and the wealth piece, right? Which is why I'm so passionate about trying to fix those things. I don't think those are different things either. I think a healthy person is probably more likely on average to be wealthy, and that wealthy might actually be more likely to be healthy, but not necessarily. But I think those things, especially the mental component of the stress that comes from financial strain, that can affect your physical health, and then you can get in a downward spiral pretty quickly. And I'm like just passionate about how do we kind of reinvent the structure that we have in U.S. healthcare, because we have the resources, we have the people. I think we just need better incentives. That's really where I think we're missing a mark right now.
I agree. And I think that we need better incentives, and we just need to be thinking more about that end consumer.
Yeah.
Pareto Health is the largest benefits captive in the United States. With nearly 3,000 captive members, $1.3 billion of stop-loss premium in force, and almost 1 million covered lives, no other benefits captive comes close to Pareto Health's scale. But it's not just about the numbers. Pareto Health is a mission-driven organization, and that mission has two distinct parts. Number one, to make self-insurance simple and more accessible for small to mid-sized employers. And number two, to arm them with the most powerful cost management tools on the market. So if you're an employer frustrated with your healthcare outcomes, or you're a benefits consultant looking for an alternative to the status quo, it's time to consider Pareto Health. Pareto Health, where employers come to do self-insurance right, to do it easily, and to do it at scale.
Well, so I don't know if there's any steps along the way in that 23-year journey that you want to pick up on, or if we move into Oxbridge right now. But, I know we could spend half an hour probably on your CV, but are there any kind of crucial steps along the way that you want to make sure to highlight?
It was really when I came on it Friday and helped to launch that plan as well, launching it into Texas from Colorado and a few other states. But that was really where I could see a shift.
Okay.
In this really consumer-centric healthcare, health insurance, where you're taking in the end consumer, you're taking in their journey, and you're understanding that, where it's not just, your member is not just a number. And yes, that was an ACA plan, but the fundamental, your member is who you should focus on. Mm-hmm. That is where I live. And so that experience for me was incredible, and I miss it every day.
Okay.
So
fair enough. Well, so then we're going to focus on people then. I mean, I know we'll talk about the technical conversation on episodes of care and corridors and all these kind of fun words, but ultimately this is about how do we make employers kind of more responsible and empowering employees, I think, to make better decisions about a big components of their healthcare expenditure. So what got you to Oxbridge, though? I want to hear the step into Oxbridge, if you don't mind.
So Oxbridge was... I know folks at Oxbridge. I know the CEO very, very well. And so we had a great conversation about what Oxbridge is doing. I was a consultant at the time, and I wanted to be a part of this. And it was really about the transparency of healthcare that made me want to be a part of this organization, and bringing in this transparency to the consumer, bringing in the security and the safeguards of an episode benefit plan. Really these kind of lanterns or pillars that we have around bringing these plans and this type of care to the end user.
Okay. And so how long have you been with Oxbridge? I know you guys are launching for 3/1 effective dates, but how long have you been behind the scenes right now?
Yep, I started in May of 2024.
Okay.
So going on, 9 months now?
Okay, awesome. Well, and I'm sure you're going to be sort of instrumental in the actual growth trajectory, and you guys are coming live 3/1. But I think when we were talking over coffee and beforehand, you talked about there's like kind of 4 main pillars to the structure of it.
Right.
So my goal today is people, whether or not they go, I like that, or I want to deploy that or not, they go, that's interesting and I understand what it is, because I think you guys are really expounding upon this ideas of surgery bundles and really taking it to the next level, in my opinion. Yep. So why don't we just talk about those 4 pillars, and I'm sure I'll ask you questions throughout.
Sure. We can go kind of front to back or back to front, but really the 4 pillars of Oxbridge, episode benefit plans, we really think is the future of healthcare.
Okay.
Consumerism drives transformation. That's another pillar. Then we have the consumer choice and predictability.
Okay. Well, let's do the episodes first, right? So what would you define as an episode? Maybe we use an example to make it really concrete for people.
Sure. So we have procedural episodes. So that would be, think like a joint replacement, hip, knee, shoulder. Mm-hmm. Procedures are things that are kind of predictable. You're going into them, they're shoppable.
Okay.
Right? So an emergency is not going to be an episode like you break something, right? You don't really get to shop that. You just want to get
dangling, but I didn't go shop around for care. That's probably not happening.
Exactly.
Okay.
Please don't.
Please don't. Call 911.
Call 911. If you see bone, go to the emergency room. Then we also have conditions.
Okay.
Which is something that's fairly unique to Oxbridge, which is, diabetes, heart disease, arthritis, asthma, Crohn's, these things that people are dealing with day in and day out, that they need, sometimes daily medications, regular testing, regular MRIs. Rheumatology sits really close to my heart. My daughter has arthritis.
Okay.
And has since she was 4. So it's like, I know junior rheumatoid arthritis. I know what sort of an individual needs to go through for that. Then we also have maternity episodes. So we can put guards around maternity. So that's, your pregnancy, vaginal delivery, C-section. So these are all episodes that are wrapped into Oxbridge.
Okay. And so how would you say that, I kind of understand because we've had dialogue together, but how would you differentiate this from a typical bundle, right? I've told you, Keith Smith's kind of famous for doing the bundles in Oklahoma. That's a true bundle for something like a knee, and it covers that episode of care, and it's just the bundle pricing and a transparent pricing. But what layers are you guys adding on top of what we think of as a traditional bundle?
So this is just really far more comprehensive than your sort of single point solution, right? There are people out there that are doing bundles for a knee or a hip. There's really not a lot of episodes out there for conditions, but we're taking all of these episodes and we're putting them into one plan.
Okay.
Right. So you have your base plan, which is your deductible, your coinsurance, your copays, your fee-for-service things would be covered under that, like if you break your leg. But then all of our plans have all of these episodes wrapped into them. And so you don't have to go to a different point solution in order to get these. You don't have to implement something on top of your health plan in order to get this sort of protection and predictability. It's just there.
Well, I know you know that we're focusing on the employee experience, but the employer is ultimately the one bringing this to the fold, right? So
100%.
Talk to me about the choice that they have and kind of how comprehensive that network is, the financial structure. I want to hear about that because the corridor and some of the burden that's now borne by the employee based on the choice they make is really pretty interesting. And you're giving some control to both parties in that equation. Let's talk about that.
We are giving an incredible amount of control to the employer. So when you're talking about an episode, we're putting an allowance around this bundled care. And remember, that is everything from diagnosis to recovery.
Okay.
So if you're thinking like a knee replacement, that seems to be a fairly common procedure happening nowadays. Not sure why. I guess we all did major
I
damage
guess
to
we
our
all
knees.
screwed up our knees. Yeah.
Yeah. But you're thinking your specialist visits beforehand, your imaging, your prescriptions, your surgery itself, the facility, the anesthesiologist, and then you have follow-up physical therapy in order to just get better from that and get back to a normal knee. So we take all of that and bundle it together. We put an allowance around that, which is guaranteed to the employer.
Okay.
So let's say, for example, it's a $30,000 knee replacement. Mr. Employer, the most you're going to pay for that knee is $30,000.
Okay.
Then we allow shopping. And this is where that sort of consumerism in transformation comes into play, as well as choice.
Okay.
We don't narrow our network. We don't attain savings through a narrow network or through putting things on like an RVP maximum, right? We have the allowance. The members come onto our member portal or the member app, or they speak to one of our episode advisors, and they shop the care groups in their area. And when you look at that page, it's like shopping for a flight on Expedia. Or shopping for a hotel through Kayak. You're looking at all of the different care groups in a list. Some may be the same doctor performing things in a different facility, but then you're seeing the entire price of that episode.
And so if that threshold, right, you mentioned as an example, like this isn't concrete, but an example of $30,000 threshold for a knee. Does the employer, they have the choice to sort of dial down or dial up that threshold at their discretion?
They do.
Okay.
They do. And so...
Because, depending on where you are, New York might be more expensive for a knee bundle than Oklahoma City, again, as an example. So they might have to tweak the thresholds a bit to be more comprehensive in nature, right?
Exactly.
Okay.
And so we have levers that employers can pull. We typically go at the 70th percentile, but we can go up to the 80th, the 90th, we can go down to the 60th. So that is one of the options that employers have to achieve savings, and to achieve savings year over year.
Okay.
Right? If you're brand new coming off of a fully insured plan, you might want to go to the 90th or 80th percentile until people get used to that.
Okay. And that will give you more options, right? As a result, if you dial up the percentile, it means more choice is going to be available based on that threshold?
More choice under the allowance.
Under the allowance. Yeah.
Correct.
Again, so we'll cover that next. I think we're not limiting choice, but you're creating choice underneath an umbrella or a threshold of allowance.
Right.
The higher you dial it up in terms of a percentile, the more likely there's going to be more options under the allowance, right? Do I have that correct? Okay.
Correct.
Okay, so you say typical 70.
Typically it's 70. That's kind of what we're going out with. And so that gives a tremendous amount of selection for under the allowance. And then when an employee is shopping under the allowance, the employer is then sharing a portion of that immediate realized savings with the employees to lower their out-of-pocket.
Okay.
So someone chooses, let's just give it a scenario, and someone has a $3,000 combined deductible out-of-pocket max. Great. They have a $30,000 knee. They choose a $25,000 care group. Employers sharing half of that immediate realized savings with them.
Really? Okay.
Right. That's just a scenario. That's the shared savings is another lever that employers can pull. But in that scenario, the employer is now sharing $2,500 of that immediate realized savings going towards that $3,000 deductible out-of-pocket max.
Okay.
So now...
So they're getting credited for it, essentially.
Yes.
Yeah.
So now, instead of this knee costing this person $3,000, it's going to cost them $500.
Okay. And
Right.
the more, if like I want to try to play that scenario out though, let's say I found a $15,000 option under that $30,000 threshold. In theory, their kind of financial out-of-pocket burden could be completely offset
Yes.
with that choice. Okay.
It certainly
But the
could.
employer
And they
gets
could
to
bank.
dictate that at the front
Yes.
end. Okay.
They do. The employer gets to dictate that the percentile, the shared savings, and then the corridor.
Okay.
And so we'll talk about
Yeah,
the
let's
corridor.
explain the corridor.
So the corridor, think about that like a donut hole. which is if someone does choose to go over the $30,000. Remember, we're not limiting choice here.
Right.
You choose to go where you want, where you think you're going to have the best care. Under the allowance, those are incredible doctors. That's very, very great service. But you can choose to go over the allowance. And there's a corridor that is a non-covered expense that would incur, say they chose a $32,000. Well, now that $2,000 is going to be employee responsibility because we're still guaranteeing the employer that $30,000.
Okay.
And then if they go over the corridor, then that comes back into the plan, pays it fee for service according to whatever their deductible coinsurance rates are. If they've already met that, then of course the plan would pay at 100%.
Okay, so I want to walk through those three scenarios and I want to kind of restate because I know it's a little bit technical with a few moving parts, but I think that's really good and it's really interesting. So under the threshold, the employee gets the potential to share in the savings that the employer realizes, and that can be credited towards their deductible or out-of-pocket costs.
Correct.
Middle scenario is I get it exactly at $30,000. There's no shared savings, but the threshold is still sort of met, right? So there's no additional financial burden the employee has to bear.
Correct.
And then the third scenario is that employer gets to choose a corridor of additional financial exposure to that employee. And then once that's satisfied, the normal plan kicks in after that.
Exactly.
But you designated a non-covered expense. So can you differentiate that for me versus something that would apply to my deductible as normal?
Right. So when you're in the corridor, that is the money that's being spent in the corridor is not being applied to deductible or out-of-pocket expense. It is truly not covered.
Okay.
So that is employee responsibility 100%.
Okay.
The employers have the ability to set whatever that corridor is. Down to the lowest at around 5%. And when we're talking about percent of corridor, it's the percent of the allowance. So a very round number example would say you have a $10,000 allowance and a 20% corridor. The corridor would be $2,000.
Yep.
Right.
But the point is, and again, I don't want to take us in the weeds too much because this is interesting to me as the captive guy, right, with the different layers of risk. But I think the point is the individual going in is now empowered to make the right decision for them in that situation. They're not being forced to do anything.
100%. They have the entirety of the network at their disposal. They can make the choice that works best for them. Right? For a knee replacement, they may be saying, great, I want to go as far under the allowance as I can because I know that I'm getting great care and I want to get that savings. For a heart transplant, maybe they're wanting to say, I want to go to the best doctor in the world.
Having spent years working alongside healthcare leaders, brokers, and employers, I know how overwhelming healthcare can feel for our customers. We've all been there. Those renewal conversations that never seem to get easier. Rising pharmacy costs and medical costs, and no real transparency into where healthcare dollars are going. That's why I'm excited about Nomi Health. They're not just fixing the old system. They've rebuilt self-funded benefits from the ground up. With Nomi's network, you can offer something truly different. No copays, no deductibles, zero out-of-pocket costs when members see a provider. It's the kind of benefit that makes everyone ask, why hasn't healthcare always worked this way? Ready to bring your clients something different? Visit nomihealth.com and see how Nomi is rebuilding healthcare, one employer and one community at a time.
Right, which leads me to a follow-up question. I'm sure there's going to be a skeptic going, well, okay, you're driving them to really bad doctors, right? I mean, the skeptic's always going to suggest that that's the case. So I have no doubt, but I want you to kind of have a chance to address it. There's quality components to this choice as well. Right?
100%, yes. I mean, we are looking at efficiency and quality and looking at the network. It's a fully credentialed network. We're not driving people to bad care. It's very high quality, low cost care. Based on where they are, based on their age, based on their risk adjusting, that will make the allowance. But these are incredible doctors that just happen to be under the corridor. And how we're getting that is that we look at all of the information that just really is supposed to be available to every human being through machine readable files, but they're machine readable for a reason. And so we're looking at the data. This is backed by hundreds of millions of data points.
Okay.
Looking at what each doctor's quality is like, how many procedures they're doing, what is the cost of their procedure, what is the cost of the procedure if they're working in hospital A versus hospital B, right? And so we are doing all of that so that the consumer, the member, the employer doesn't have to be a medical director and go back and start doing all of this themselves.
Yeah. Well, there's a few follow-up questions. This is fascinating conversation for me. So I'm going to pepper you with questions and my brain's going all over the place. But if we could put a pin in, how do we get the doctors to be a participant in this down the road? I want to go back to the shoppability component.
Yeah.
Because in order for this to work, it has to be really simple for an individual to figure out, right? They have to be able to log into the Expedia of healthcare and go, okay, I know I need a knee replaced. Okay, the threshold is this. And okay, my burden is this if I choose here. I might have a financial incentive if I choose here, but it's got to be super simple. And then I think you guys add a layer of kind of healthcare navigation or coordination on top as well. So let's address, how do we make it so obviously simple that people wouldn't want to choose anything else?
It is the most incredible website, right? You're looking at this, it's color-coded, right? At the very base, it's color-coded. So then we're listing it from kind of lowest to highest, really in the way that people shop naturally, right? And then with filters and sorting options of how you want to look at it. But then we're color coding. Green is below, red is above.
And is it actually showing projected financial implications of these choices in real time?
Yes,
okay,
it is. So each member portal, and every time a member calls us, you, Spencer, are a member, you call me. I know as an episode advisor what percentile you're at, how much shared savings are happening, what the corridor is, and this is unique to each individual and company that comes on because everyone is going to choose something a little bit different, right? So it's telling you in real time, this episode of care, this care group is X number of dollars. You're going to receive X number of dollars in shared savings. Your anticipated out of pocket is X. We do give a good faith estimate. It says, great, you've said on this $30,000 knee, you've chosen a $25,000 care group, and you're getting $2,500 in shared savings off of your $3,000 deductible out-of-pocket max.
Okay.
Your anticipated out-of-pocket for this knee replacement is $500. All of that information is going in right in front of you.
And do they actually, quote unquote, complete the transaction in that website as well?
They do.
Okay, so then there's like, I've made a choice. I understand, hey, I might be getting a little bit of money back, or I'm going to get some applied to my plan. Awesome, great, let's do it. Am I scheduling through that portal as well, or is that the episode advisor then helping get the schedule?
The episode advisors are helping to get scheduled. You can schedule through our website. We have people available that are employed by Oxbridge. So they're sitting in our headquarters is in Norwalk, Connecticut. They're sitting in Norwalk. They understand exactly what these things are doing, what the episode is, what the allowance is, how to walk someone through that, how to explain that to an individual if that's what they need. We're trying to really meet people where they are. Some folks are going to be very sophisticated shoppers, and they can do all of that through the website on their own.
Okay.
Some people may not be, and they want to talk to a human being.
I want to talk to a human being.
Yeah.
I mean, is something as complicated as this. We talk all the time about AI's role in healthcare broadly and what things it can do maybe better than a human and not. I still want the reassurance of an expert that I'm talking to that understands this to tell me, okay, yep, confirmed, your understanding of this is correct. Here's a good faith estimate. We'll help you get it scheduled. I gotcha. Like I really want that I gotcha response from another human.
Exactly. And that's what we provide is that reassurance from someone, even if this has happened as far back as I can remember, that someone will make the decision on their own, but then they'll call to be reassured of that decision.
100%. Yeah.
And so that's what we're here for. You can make the decision on your own and be perfectly happy in that. You can make the decision on your own and be reassured for that. Or you can make the decision entirely on the phone with one of our episode advisors.
I love that.
Chronic health issues, surprise out-of-network medical bills, inflated medical and prescription drug prices. These issues cost self-insured employers hundreds of millions of dollars every year. Add to this the rising cost of care and potential for waste across the life of a claim, and it's clear that self-insured employers need innovative solutions that lower their health plan spend. At Valence, we've done just that, developed innovation that shifts the current paradigm. A complete and integrated ecosystem solution driven by data, one that manages and simplifies the complexity of medical claim costs. It is through analyzing millions of data points that we enable employers to realize and fuel cost-saving solutions. Valence experts come prepared from day one, targeting the fraction of claims that will drive the majority of health plan costs. That is how our team lives the Valence promise, engaging early and often for smarter, better, faster healthcare.
And so are there ever any situations, though, I know you said the employer doesn't really place restrictions. They get a chance to tweak the dials, right?
Yep.
But is there ever one where like, oh, if you go here, it's 4 times as much as anywhere else? Are there ever any sort of like top end, you can't really do that? Or is it still the option just to go to a normal network choice and it is what it is at that point?
You have the choice of the entirety of the network.
Okay.
Even if it's 4 times as much. If that's the care that you think you need, you have the choice to make that. And we're going to lay out the implications of that in its entirety so that you can make an educated decision.
Right.
That's the thing. You have to be able to make an educated decision. So there's no gotchas.
Well, it's not so much that it's a gotcha, right? But you obviously understand the variability of cost, especially based on who the payer is and the contractual arrangement there, where it's just like they're completely inexplicable, the cost differentials. And you go, why is it exponentially more to get the exact same procedure over here because somebody else is paying for it than if I did it right here? It's just mind-boggling, right? It gets me really frustrated. So can you envision, and I know we're rolling out live for 3-1, can you envision employers sort of coming back to you guys and say, hey, could I put a guardrail on the top end? Maybe it's 2x or 3x. Could you ever anticipate that type of demand? Or is that something that you guys don't think will happen?
You know, I'll never say never.
Okay.
I haven't really discussed that at this point because we're not limiting the network.
Yeah, and that's totally fair. I'm sort of asking outside the box question, but it's one of those things I'm like, I was trying to think about, well, how could this get gamed or how could an employer still perhaps not get the outcomes they're trying to push? And the reason why I care about this is you mentioned the employee, you mentioned the individual and their experience, but I do sort of see these things as sort of codependent. Because employer wants to offer amazing health care to their employees. Well, the better choices the employees make it, the more likely they can offer higher value health care options for their employees. And so you have this cycle. It can be a vicious cycle and a negative spiral, or it can be a really good cycle that moves towards positivity. But I don't think it's a completely separate equation to have employee choice or employer choice without thinking of the other one as well.
100%. And, you know, the employers have that choice and those options saying, I want to go to a higher percentile. I want to allow more under the allowance. I want to go to a lower percentile when they've really had people have the ability to become very sophisticated shoppers. We're still guaranteeing each of those episodes. Right.
And how many? Do you have an idea of how many episodes you guys cover?
128.
128 episodes. That's a lot. Okay.
It is a lot. 128 episodes.
And do you envision that will grow over time as well as you get better data coming in and make it more predictable? Okay.
Correct.
Yeah.
You know, and starting to add more and more and more into this episode benefit plan where we're putting a guarantee around that. And so, yes, for that person who wants to go to the 3, 4, 5 times, whatever that might be, they can do that. But it's not going to change the guaranteed allowance.
Well, and it's still, they're making a conscientious choice or conscious choice, if you will, at that point. They're okay with dealing with the added financial burden to them as an individual for making that choice.
Exactly.
The employer's obviously going to be aware in the claims data over time that happened, right? And it's not like they're going to admonish that person for making that decision, but it also might be an opportunity for a teaching moment or a continual education. Oh, by the way, guys, like this is how it works. And we want you guys to save money. And this is why, because I don't think this is something you necessarily just flip a switch on and everybody immediately probably makes the most optimal decision. It's going to be a gradual thing because you're talking about changing human behavior.
We are.
Yeah. So a couple things. What happens with a complication, though? You guarantee a cost, but complications arise in surgery. So knee surgery didn't go as planned, get an infection, multiple day hospital stay for a sepsis or something like that. Mm-hmm. What happens then? Still guaranteed at that threshold to the employer?
So if it would depend. If you have something like sepsis, or and you're going into the hospital, that actually is going to trigger a second episode.
I see. Okay.
And so we're going to put another allowance around that hospital stay.
I see. Okay.
Right? So that would be a sequela or a complication. Mm-hmm. If for some reason, so that's what would happen in a complication type situation. It could trigger a second episode, mm-hmm. or we may just adjust the allowance on the original episode.
Okay.
If we go in for the knee and those claims just come up higher than expected, right? No really complications, but it's just not what we had sort of predicted.
Yeah.
We eat that cost.
You do?
Yes.
Okay.
So we have skin in this game. We are a risk-bearing entity. So you go in, you follow your care group, everything is fine. And those claims just come in, if we guarantee at 25 and they come in at 27, we're going to continue that guarantee at 25.
And then you guys, I imagine, probably try to go have conversations with the physician or the facility to try to negotiate that down, right? Or sort of use data to say, hey, this is what our data says you're accepting as a rate. Can we write this off? Or what's the negotiation process on the back end? Or do you know yet?
Well, I'm not exactly sure.
Okay.
Because we haven't really talked about how to not pay that.
Yeah.
Right? Because we are so confident in our work.
Well, you said you have millions of data points, right?
Yes.
And this is real world data. This isn't guesses, right?
Correct.
This is real world data. So you can get really, really specific and precise on those thresholds. But this is the world of U.S. healthcare, right? So anything that can happen likely will happen. One thing I do, though, I told you to put a pin in it. I'd love to talk about the physician side of this, right? So what involvement or what transparency do they have in kind of this equation when a member chooses to go to the facility and get their knee done by Joe, the doctor, knee surgeon? Are they aware that this cost structure is in place or no?
So right now, we use Healthcare Highways as our network.
Okay. Yep.
And so we've kind of built the episodes and the allowances around, again, hundreds of millions of data points from their MRF files, from Clarify data, and so we're sort of building it around that.
Okay.
We know what these things are going to cost for each person, where they are sort of in where they live.
Yep.
When we direct contract any type of network, then yes, the doctor, now we're negotiating specific claims costs, specific procedure costs. So right now it's being worked off of data. And then as we continue to grow out the network, then it will be more involvement with the physicians. Yeah,
because I like it. What it's doing, though, is over time creating the right incentive structure for the physicians in the facilities as well, right? Because so oftentimes we'll talk about kind of the consumption side of the equation, but we sort of ignore or don't worry about the delivery side of the equation. But I would love a world where doctors are incentivized to help drive down costs as much as possible without reducing the quality of that procedure. And I think that's part of what's missing right now is there isn't the same incentives for them to drive down costs, unless right now you separate yourself from the insurance model altogether. Very few are doing that. And so you don't have the right incentive structure on the delivery side as well.
Right.
And I think this is going to be pushing on both ends of the balloon, if you will, to make that happen.
It does. And as we continue to build out our direct contracted network, then that will only emphasize that more.
Well, and so we were talking about, that's more acute procedures, but you mentioned earlier the ability to manage more chronic conditions like a diabetes or a Crohn's.
Yes.
How do we turn that into a bundle? Because that's outside of my understanding of what a bundle usually is. So how can you still make that predictable?
Well, you think about diagnosis to recovery. And so we know everything that is going to go into an annual care of a chronic condition. So we have doctors and nurses on our staff that have built episodes from the ground up. We've gone through everything that's clinically related to diabetes. We've gone through, and that's not just diabetes, but diabetes type 1, diabetes type 2. We know what's clinically related to arthritis.
Okay.
Right? And so we're looking at the market and what everyone in that market is using, kind of 70th percentile again, what 70% of that market is using to treat these. And it's all falling into those episodes and being able to give that transparency for that full year chronic condition.
Okay.
You know, diabetes type 1 does not go away.
Right.
Arthritis does not go away. And so these folks are dealing with this throughout the year. And so we know this is what's going to be involved in that. This is the testing that's involved, the prescriptions, the, insulin, daily testing strips, A1Cs, all of these things that you're going to have to do in a year-long thing. These conditions aren't new. We know what people have to go through.
Right.
So you just look at the data around it.
Well, and then so does that member still have that same level of choice in sort of participation? Okay, so then how would you handle that kind of choice structure for a more prolonged episode like that?
So it's the same kind of deal, right? You choose your care group, which is going to be your primary care or your podiatrist or your endocrinologist, whatever it might be, and then you're choosing your care group for that year.
Okay. Right. So it's a kind of a full year decision, right? Then
it is.
Something like that. Okay.
It is. And people can change their care groups throughout the year if they would like to. Sometimes your doctor retires, right? Mm-hmm. So then we would just choose a new care group. But the same structure applies. You have care groups that are above, care groups that are below. If it's below, you still get that shared savings. And it goes towards co-pays or prescription cost, whatever the medically related needs are for that episode.
Well, see, I like this because it's ignoring things that a normal bundle would sort of ignore those continual treatment patterns.
Right.
And they deal with more acute. But something like a situation where somebody's type 1 diabetic, right? That could turn into something acute really quickly if that was poorly managed. Right? And so that could be a catastrophic event could result from that. And so those two things are not necessarily separate things. And I would love over time, right, you guys are probably expanding as much as you can into additional conditions. To just really add a layer of sort of like, I think predictability is I think you said one of the pillars to it. But the predictability is what's missing a lot in healthcare these days, especially, well, I wouldn't even say especially for employers and employees too. They just have no idea what something's going to cost going in. I would love if I was a type 1 diabetic and I knew for the full year, I've sort of got a care plan put together. I've chose a care group. I have a very high likelihood of understanding of what this is going to cost me. And I might even have some choice to help lower that cost that I could get some incentives in doing so as well. I would probably be more adherent to my medication and my treatment protocol too as a result of that, because I don't have the anxiety of not knowing as a result of the old traditional model.
Correct. And when we talk about predictability and talking specifically about employers, right, these 128 episodes can really control the cost of about the top 50% of their annual medical spend.
Really?
Yes. So we're not just talking about I mean, like I said, I'm very sort of individual centric, but the employer has the ability to control that 50% of their medical spend. You know, those things that are high cost, sort of predictable, you know, the lower 50%, those are your urgent care, emergency room, kind of you got a cold or a flu. But at the top 50%, now you can control that. And I even tell our brokers now, send me last year's claims. I'll tell you exactly how much we could have saved this employer based on last year's claims.
Right.
And let me look at that. Let us show employers, this is what you can save on this.
Well, do you have, and I know it's still sort of nascent and new, but do you have an anticipation of, like, if I was an average employer and you're impacting that top 50%, kind of what we expect an employer to save across their health plan each year? Is there a number that you guys have tried to put it to just yet?
We have it at between 10 and 30%.
Okay.
And why there's kind of that large of a spread, right, is because of all of the levers that employers can pull.
Right. Some of it is based on their own choice of how they set it up in the first place, correct?
Exactly.
Yeah.
And so the employer has so much more clarity, control, predictability when they can choose, I want to go at the 70th percentile. I want to do a 25% shared savings. I want to do a 20% corridor. They're going to achieve more savings.
And do you, with that choice, do you also give them projections on the front end of that? Is like, when they're turning the dial for themselves as an employer, do you say, hey, this is going to be a little more aggressive, this is a little less aggressive, it should result in X? Yeah. See, that's what I would want as an employer, right? Because a lot of times people get sold these point solutions, and yours is not a point solution, as you said.
Nope.
But you get sold a point solution, and you go, God, I have no idea if this is going to work or if I'm going to save any money at all, but it sounds nice, let's give it a try. I think this is much more tangible for me if I was an employer going in and making decision, because you're giving them data points, you're giving them visibility into how you set it up, you give the employees visibility in how they make those choices. And so it becomes far more predictable ahead of time what you're probably going to save as a result of that.
Yes.
Yeah. That's,
Exactly.
I like that, right? Like that predictability component. Yes, transparency is great, but transparency, unless you have good incentives to make people, hopefully on average, choose better outcomes as a choice, means you're actually going to get predictability. Transparency without any other sort of guardrails in place is simply just getting transparency to how you're getting screwed. I would like to get a little more brass tacks, if you don't mind, because you mentioned brokers a moment ago. So I presume you're working through the consultant or broker channel most for sales distribution?
You know, about 75%, yes.
So what would happen outside of that channel then? Is that more TPAs, or who would you be partnering with, or direct to employer?
Direct to employer.
Okay.
So we are going direct to employer. I am also very broker and consultant centric.
Same. Yep.
And so I think what brokers and consultants bring to the table is very, very valuable. And the relationships that they have and the ability to influence. And so we really do like to work with brokers and consultants to bring this to their clients. You know, we do direct to consumer or direct to employer. It's really for brand awareness, and we want them to bring in their broker.
Sure.
Yeah.
Yeah, oftentimes I'll get connected with an employer and they're interested in like Pareto, and it's like, well, hold on. I love that you're interested, but let's bring your consultant into the framework, because I do think they play just such a crucial role in this equation, right? And, you know, sometimes you'll get consultants, or the consulting in general gets a bad rap because of some of the bad incentives. But in the end of the day, there's such a force multiplier for these type of things. And the really good to great ones are helping make the employers help make the right decision. And they can do it at scale because they have access to many of them at a time.
Exactly.
Dumb question, but does the group have to be self-funded to do this, or could it?
No.
Okay, so not a dumb
I
question.
mean, well, they would have to go self-funded.
Okay, but yes, so they would have to go self-funded to do it. Yeah.
But we can do fully insured conversions and level funded conversions, but they would have to go self-funded. Yes.
And are any recommended or sort of TPA limitations or things like that? Because I really would like to help a consultant in his or her mind build out how I would deploy this. And I'm sure there's other moving parts they need to consider as well.
So we are the TPA.
Oh, you are the TPA?
Yes.
Yeah, I forgot this. Okay, but let's go ahead and talk about that real quick.
We are the TPA, so we do all of the claims payments, we do all of the customer service, we do all of the billing. We're a fully functioned health plan.
Okay.
We will work with other TPAs, and we have some other options available to do that. Right now, we're kind of treating those TPAs as a broker.
Oh,
right.
okay.
And so there's not many that we're working with now, but we take on all of those functions in-house. So everything is sort of self-contained. When you're speaking to us, you're speaking to Oxbridge.
Well, I like that. Okay.
There's not this, oh, well, my claim is going through here. No. You're calling Oxbridge, you're speaking to Oxbridge.
And then what about the pharmacy side then? Do I still have the ability to carve out my own PBM, or are you guys bringing some of those solutions too?
We have the PBM as well.
Okay.
So we use RX Advance as our PBM. We pass through 100% of that rebate. So we're bringing a fully formed health plan to every broker, right? We try to be very flexible. So if you want to carve out your PBM, we can certainly discuss that, but we'd prefer not.
Yeah, no, I understand. And all things being equal, right? Like there might be some give and take on both sides of that choice, like whether I carve it out or keep it carved in.
Right.
But there's also a really strong argument for the cohesiveness in the plan in and of itself, right? I sat down with a gentleman, Ryan Copland from Health Wallet, a week or two ago. And one of the things we talked about is like when you unbundle everything and get the best in class vendors of each thing, we still got to talk together. They still have to be cohesive. The plan still has to work, because no solution will sort of reach its sort of maximum outcome if it doesn't like commingle and interact with everything else in the plan. Right. And so I think the fact that you guys make it somewhat turnkey is actually probably a really good thing on balance. And then it's up to the consultant to evaluate the strength of the individual components. Does that include a stop loss or reinsurance component as well?
It does.
Okay.
And so we partner with several stop loss vendors that have our data. And that's why it kind of comes from, we're shopping the stop loss regardless. You don't have to use our stop loss. You can use your own if you want to. You're probably using one of our vendors, which, because they have our data with around all of these episodes, that can impact the premiums for the stop loss.
1,000%. Yeah. I always talk about the stop loss carrier as the independent validator of whether something works or not, because ultimately they're the ones that are bearing the risk on that plan. Yep. And they're pricing the risk according to the structure of the plan itself. And so if they're willing to offer lower premiums or lower aggregate factors because of the inclusion of an Oxbridge, they're validating, at least on paper, they believe it's going to work, and they're taking the risk. They're putting their money where their mouth is ultimately. And so I always encourage somebody, is not you guys because you guys have a lot more experience, but somebody that's new to the healthcare space that's trying to validate what they do and the cost savings they're projecting. Get a stop loss carrier to look at your data. They'll tell you whether or not they believe you.
Get those actuaries on there.
Yeah, get them on.
That is a mind that even I don't understand sometimes.
I like to pretend I can speak to an actuary, but it's very difficult. It's very surface level. And we'll talk offline on who those carriers are. I don't want you to have to say it out loud, but I'm sure there's some overlap with what we do. But I want to land the plane for you on some of the other sort of like brass tacks, blocking and tackling. Is there a size component to this? Is there a minimum sort of threshold you guys would need for this to work?
We're in the mid-market and the large group space. And so mid-market to me is 100 plus, really. So 100 to 1,000 is really the mid-market. And then, of course, 1,000 plus. We're opening up for 3-1. So we understand that a lot of the larger groups have already made their decision.
Sure.
But, we're ready, willing, and able to take those 1/1/2026 even at this point for the larger group.
Yeah, no, and it totally makes sense, right? Because what you're talking about is, let's assume maybe somebody's already self-funded, right? And they already have a TPA and a network they use and a PBM and even a stop loss carrier that they use. No, but that's a lot more of an involved decision, and you're going to need more runway to be able to make that, right?
Right.
And so totally get the time frame for that. But it's good to know you have a launch date, right? And we're going live. We're working with people now. And so the middle market space, I think, is one of those spaces that's probably underserved. I mean, there's a reason why I chose to join Pareto, and there's a reason why we've had a lot of success there, is because those employers in that middle segment really haven't had great options.
Right.
But they have the same needs and they have the same level of sophistication as some of these really large entities. They just don't have the same level of choice of solution providers.
Exactly. I 100% agree with that. And so we want to bring that to these kind of mid-market employers. We're already working with several, getting quotes out now for their 3/1 renewals. Quite a few have come through us from fully insured conversions.
Yeah, I believe it.
I'm hearing the stories every day of very large annual increases that we can really impact that financial cost for the employer while still bringing a very rich benefit to the employees where they don't have to narrow their network. They don't have to go RBP. They can have the choice. They can be a consumer. They can have all of these episodes available to them, and they can predict their costs throughout the year.
Yeah, I love this, and honestly, I love where you guys are going with this, but I love where healthcare is going right now. You have to dig below the surface a little bit of the products that are often being touted, but we're developing a healthcare 3.0, if you will, where I think what's really happening is an alternative healthcare system is actually being created. The infrastructure is being put in place for an employer to actually leave the old model completely altogether.
Yeah.
Leave it
just
behind.
leave it.
And we're actually seeing some of that shift. It was a Benefits Pro article, and I'm not sure if it was sourced through McKinsey or somewhere else, but I actually saw last year that there was a 3% decline in fully insured enrollment in the group space. And I think there was a 1.8% increase in self-insurance. So I don't know what accounts for that other 1.2% gap. Maybe it's an ICRA, maybe it's something else. But what it's showing to me is we might have reached a peak for the fully insured market, and now we're going to see a decline in market share, and we're going to see more and more people choose to come over to self-funding.
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans and allowing them to create an environment where we ensure that the benefit plans are being charged on a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
Well, there's four words that come to mind for me, and these are kind of your pillars, but there's predictability, there's transparency, there's cost savings, right? Potential for employer and employee.
Year over year. And also, you're not sacrificing quality, which is a misconception a lot of people have, which we touched on a little bit earlier, is the fact that something that costs more doesn't equate to a better outcome or better quality in healthcare. Often, it's the exact opposite. Exactly.
So if we're answering those four pieces, it is absolutely inevitable in my mind that employer and those employees are going to save money and be happier as a result.
And 100%. And this, what Oxbridge is bringing to the market is going to really change the market, where people will start to demand the ability to shop these groups and be able to say, I want to know before I go in what this is going to cost me. And we're giving them the total cost so they know what it's going to cost their employer.
Well, I think it's brilliant. And I wish you guys nothing but success. And I know you will be successful in this because it's a very compelling value proposition. But why don't we do this? We'll close out the podcast. We didn't even touch on the fact that you had a nightmare getting in here from the Austin area.
That's
I'm very sorry about that. We'll lament over lunch if you want about that. But I always ask the same two questions to everybody that's in the hot seat on the podcast. And so I'd love your perspective on this. First one being healthcare in the future, very near future. What is it going to look like in your mind?
You know, I think that we're already seeing this very significant change. And as I mentioned earlier in the podcast, episode benefit plans are the future of healthcare, where you're moving away from this sort of a la carte or individual shopping for each particular procedure. Or, you know, if you have a full surgery happening, like a knee replacement, you're not having to go and kind of piecemeal together your imaging and your surgery and your anesthesiologist and your follow-up care and et cetera, et cetera, et cetera. But that people will be able to see this as a bundle and see everything at once, upfront, get a guaranteed cost, That's what people are going to, when they get it, they will never want to give it away.
I can have no doubt in my mind that that would be the result.
And so once that hits the market, Oxbridge, other companies, that transparency is going to be a demand. Mm-hmm. And it is just like back in the 90s when we had that shift in prescriptions, where you went from zero transparency and now people started, oh, I can get a generic and it's going to cost me that. That drives transformation. Once you give the consumers this level of interactivity, this level of sophistication, the ability to shop, they are going to demand it.
Yeah.
And that is going to have to go into every company.
I could envision in the future, and I hope it's sooner than later, where this is the expectation.
Yes.
Like when an employee joins a new company and be like, hey, I can't shop for this type of care. I don't have transparency into the choice. Like, you guys don't do that? That would be like a question mark that they have in their mind.
Yeah.
What are you doing, right? If you're not doing that. I'm sure the Bucas will have a lot to say about that being a reality kind of in the near term versus holding off on it. But that's what we need. We need that level of transparency and predictability. We need actual real consumerism and not the HSA health high deductible health plan version, which is you just have to pay more, which is not consumerism.
Or on the flip side of that, just rather than giving people that consumerism, rather than saying you just don't have any cost share.
Yeah.
And then it's all, but they have no idea what that actually would have cost them.
Right.
Right? They're just saying, oh, no, Mr. Employer, you get it. We're not going to have any cost share to the employee.
Yeah. And if we actually want to see healthcare kind of come back down to something that we would say is like fair, and we tout ourselves in the United States as exceptional, right, in a lot of capacities. And I think our healthcare system can be exceptional. We have all the resources, we have the people, we just need the will and I think the incentives for that to be the case. And I think it is absolutely possible. And I'm going to try my best to participate in that shift. Last question then for you is, if you don't mind, give us kind of your synopsis or closing thoughts for the episode of what you want the listener to leave with.
Yeah. Well, thank you. First and foremost, for having me today, and I've really enjoyed our conversation. I just want to leave behind that Oxbridge is bringing this new episode benefit plan to this market, and how much this is going to impact their employers, their employees, just the kind of world of healthcare in general, and how important it is to bring this to the market. Like I said, I've been in this industry now going on 23 years. It seems I'm aging myself a little bit. But people deserve this.
Yeah.
They deserve the ability to shop, to see how their wealth is going to be impacted by their health. Mm-hmm. And it's not something that most people get. And so now we need to bring this. Yep. It is not, hey, we're just launching a new plan. This is something that is mind-blowingly change.
Okay.
That we can bring this to a community that needs it, that deserves it.
I'm all for that.
Yeah.
I'm 100% for that. And I think it's time, right? I think it's time. People are getting squeezed everywhere. And the economy, inflation is, it's a different conversation for a different day. But everything from groceries to gas to you name it is costing more, right? And then healthcare accounts for almost 20% of GDP. And yet we're just helpless in the most part for the traditional system.
We are.
We need to empower people to make better choices, and we will get better results as a result of that.
100%. And we can get a healthier community, a healthier nation. People don't have to worry. I mean, we have enough worry as it is. We have enough stress on our lives as it is. Where you're going to be able to pay for your health insurance or your health care shouldn't be one of those.
I agree. Well, I think it's a great place to end it. I mean, this is a fantastic, fascinating episode. I truly, truly mean that. So thank you for the effort to coming in kind of last minute as well, and making that trek. I hope your travel back to the Austin area is a little bit smoother.
I'm sure it will be.
I'm sure it will be as well. And I can't wait to release this. So I just can't thank you enough. Thanks again.
Thank you.